Well, okay. All right, let's get started on chapter 53. Who did we leave off with? Who's next?
I did number 25. So whoever's after me. So I think that's me next.
Yeah, Andrika, identify the next steps to take if you identify a young child in severe respiratory distress with labored breathing and the inability to swallow due to supraglottic edema.
Okay, I have elective intubation under general anesthesia in the operating room. Tracheostomy may be needed if the patient conditions worsens. Warrants it. Egan 1217. Okay, that's it.
And where did you find that?
Egan 1217.
Okay, AJ, what is cystic fibrosis and identify the leading cause of death among cystic fibrosis patients?
I've got a condition that causes thick mucus to build up in the body. Infants and young children cannot cough on demand, so secretions must be suctioned to prevent the buildup.
All right, you're breaking up a little bit, so where did you find your information?
1229.
So, real quick, just to recap on that. So, cystic fibrosis can be identified through sweat chloride test, treatment. You're not just treating the lungs, you're treating a little bit of everything, right? And what is it exactly that causes the issue that they have?
It causes thick mucus to build up in the body.
So with their not just with respiratory, but also stomach issues as well, tends to be a big deal. They're also more prone to infections. And what population is more likely to have cystic fibrosis?
I got infants and young children.
Okay, I should say what race or ethnicity.
I didn't get that part.
In more common in whites. So about 1 in 3,000 are carriers, where like the Asian population is 1 in 31,000. So there's a big gap there. So it is caused by mutation of the CFTR, or the transmembrane conductance regulator, and that is the gene that is basically malfunctioning and causes cystic fibrosis. So anybody remember what you have to have for a child to be born with cystic fibrosis from both parents?
X chromosome.
Yep, and both parents have to be carriers.
Right.
Okay, so both parents have to be carriers. You have about 25% chance of, if both parents are carriers, that a child will be born with cystic fibrosis. About 25% that they will be fine and not carriers, and about 50% chance that they will just be carriers. Okay.
So is it more of, I know it's the white population, but it's like for females, male, or is it even gender wise?
And then there is no, at least I don't know of there being a large gap between males versus females.
Okay.
When considering CF patients, what therapy is noted as being number one in reducing bronchiectasis exacerbations? And that would be flow.
Daily use or of the inhaled, I don't know how to say that, deoxyribonuclease, the DNase, the inhaled DNase.
Yes. Very good. That's been shown to improve pulmonary function and reduce exacerbations in patients with CF. What is a common antibiotic that is given to CF patients?
Tamoxifen? Is that Toby?
Yes, Toby. Good. And oftentimes they will, they stay on antibiotics. So they'll do like inhaled Toby and then they'll switch and they'll go on something else, kind of to break it up because they
Yeah, so that the body won't get used to the one and not work.
Correct. Right, next up is killer. Note what maternal factors are most related to the health of the fetus and the outcomes of pregnancy.
Maternal health, individual physiology, pregnancy complications, and maternal behaviors affect the health of the fetus.
All right. Shara, what technique would you recommend to assess the state of pulmonary maturity before birth?
That was amniocentesis in page 1217.
I heard what page you said, but what did you say before that?
Amniocentesis.
Yes, amniocentesis. Amniocentesis. Okay. So that is direct sampling and assessment of the amniotic fluid. Right, Amanda, what are late deceleration? Shara, we mute. There you go. What are late deceleration and what conditions are they consistent with?
Late decelerations are temporary declines in fetal heart rate, and they are associated with elevated compression and placental insufficiency.
And where did you find that?
On 1219.
All right, Andrika, it says memorize the APGAR scoring system and be able to determine an infant's score upon assessment. So you tell me, what are the 5 things that we assess? What are they low score and what are they high score?
Okay, appearance. Appearance, I have all pink and blue, pale, pulse, and then I have greater than 100, and then less than 100 is absent, grimace, cough, no response, activity, flex, facet, lamp, respirations would be strong, cry, weak, cry, and absent. And that was found on Egan 1220.
Very good. Okay, so with your APGAR score, like it said, make sure that you can score 1. So I'll give y'all 1 now and you tell me what it is. So I have a newborn with a heart rate of 60 slow, irregular respirations. They are limp. They have a grimace. And they have acrocyanosis. What is their APGAR score?
Is that a 4?
Is it 3?
I had 3.
I forgot what acrocyanosis is.
I'm gonna go with 3. 1 for heart rate, 1 for respirations, nothing for muscle tone, 1 for reflex, and 0 for color.
Okay.
Okay, so 3. So make sure, like I said, that you can score your babies. But that was good. If you got 4, probably because I said acrocyanosis versus just saying they're blue or pale or if they have pink body. But remember that most of the time they're going to use it correct terms. And they're going to say acrocyanosis or they're going to say peripheral cyanosis. They're not going to say they have blue hands and their bodies are pink or they have blue chest or blue lips. So
How did you say they were going to say that one?
they're going to say something like peripheral cyanosis.
Okay, peripheral.
Okay. Meaning like their hands or their feet are blue, but like centrally they're okay.
Yeah.
All right. Next up is AJ. What process should you suspect with a bounding peripheral pulse on a newborn infant?
So I got a patent ductus arteriosus,
Okay.
1224.
Very good. A strong brachial pulse in the presence of a weak femoral pulse suggests either a PDA or it could be coarctation of the aorta. Most likely the bounding peripheral pulses do occur because of that left to right shunt seen in the PDAs. Right, number 34, Flo, identify the normal blood gas values for a healthy infant.
So I wasn't sure exactly which ones I was supposed to put, so I did the whole chart.
Yeah.
The table 53 4 of 1224, which is your preterm at an hour to 5 hours. pH is 7.29 to 7.37. The PC O2 is 39 to 56. The PO2 is 52 to 68. The HCO, the bicarb, is 22 to 23, and the base excess is -5 to -2.2. And then
It's okay. With that, I don't want y'all to have to sit there and memorize that whole chart. Like it's just a lot. What you do need to notice is that their pH is lower when they are born. Their CO2 is higher. Their
if the
oxygen
pH is lower,
Yep. CO2 is on the higher side. PO2 is lower. And bicarb is higher. That's because of how they're self-regulating in utero. Once they come out over the course of that first 5 hours, they almost normalize. Okay. And by 5 days, they have a completely normal blood gas, essentially. Okay. Taylor, you are up. What is the Ellis ratio and what are the values for it and what does it indicate?
The LS ratio involves the measurement of 2 phospholipids synthesized by the fetus in utero. at approximately 34 to 35 weeks gestation, the ratio increases to greater than 2 to 1. An LS ratio greater than 2 to 1 indicates stable surfactant production in mature lungs.
Very good. And what do we want that ratio to be?
Greater than 2 to 1.
Greater than 2 to 1, yes. And how can we measure, how do we measure it? Like when? And how is it done?
34 to 35 weeks gestation. Would that be amniocentesis?
Yeah, so we do it by amniocentesis, and it doesn't necessarily matter as far as like what week they do it at, but it's done by amniocentesis, so it's prior to birth. You cannot do an LS ratio after, ever. There's no point. And but that's when it's normally good in that like 34, 35 week area. So we're looking for 2 to 1 done by amniocentesis, and it tells you that the lungs are mature. All right, the Shara. What conditions suggest that bronchial hygiene will be helpful for infants and/or children?
I have a question on that one. The answer is on the box 53.5.
Um, I'm sorry, from where?
In page 1227, box 53.5, I want to make sure is that the answer.
Um, so basically, what I'm looking for is secretion clearance techniques are considered if they have accumulated secretions, any kind of impairment in pulmonary function, or infiltrates noticed on their chest x-ray. Some of the kids that will benefit from this are children with pneumonia, bronchopulmonary dysplasia, cystic fibrosis, bronchiectasis, and some children with neuromuscular diseases.
Alfie, were you looking at 37?
1227.
Okay, yeah, but she was asking for 36. You were talking about 37.
Okay, I was wondering, I was like, I'm not seeing a table for that.
Yeah, I think that's what she did. She got those confused because you were asking for 36 and she was looking for 37.
Gotcha. The Shara, are you following?
Yes, ma'am.
Okay. Okay, so Amanda, we now know where 37 comes from, but you want to talk about it? Identify normal respiratory rates and heart rates for infants and children.
All right, so infants, a respiratory rate of 30 to 6, a heart rate of 90 to 120. A toddler, its respiratory rate is 24 to 40, heart rate 80 to 100. Preschool age is going to be respiratory rate is 22 to 34, the rate 70 to 90. Stage children, respiratory rate 18 to 30, heart rate 70 to 90. And adolescents is respiratory rate 60 to 22, and heart rate is 60 to 80. That was 1227, table 53.5.
Andrika. Identify the appropriate ET tube size for infants and children.
Okay, tube ID equals age plus 16 divided by 4. 4-year-old age gets size 5 ET and 8 to 10 French suction catheter. Infants and children under 12 plus age divided by 2, and then 15 and older is age divided by 2, and I found that on Egan 1230.
Very good. Okay. You do need to be able to calculate your tube sizes and your suction catheter sizes for those. Or sorry, tube length. Okay, so good on that. AJ, what tidal volume should be used to mechanically ventilate a neonate?
I got 4 to 5 milliliters per kilogram on page 1230.
So the calculation is just very, very similar to what you'll do for adults. It's just on the lower side.
Is that blue?
Yes.
I found on 1239, it's 6 to 8 milliliters per kilogram, and then if they have R, it's
Right. So there are some varying train of thoughts on these. I follow 6 to 8 really, and then 4 to 5 if they have ARDS, like it said on, what did you say, what page it was? 1230.
1239.
So basically, again, like I said, just like adults, if they have ARDS or if it is a bronchopulmonary dysplasia baby, then I'm going to treat with lower volumes, okay? Because I'm going to really watch my pressures with both of those. But typically 6 to 8, but leaning toward that lower side of 6 for normal. You should not see questions that are going to give you multiple answers that both appropriately fall within that category, okay? DJ, you answered that. So Taylor, identify the appropriate eye time to use for time cycled pressure limited ventilation.
Between 0.2 to 0.4 seconds for neonates and up to 1 second in teenagers.
And why are my eye times so small?
To increase accuracy.
Is this for anybody or for Taylor?
Anybody can answer. Fine.
Could this be just because we don't want to cause any trauma? So, right? No.
That is the end, but the real reason is they have short eye times because they have short cycle times because they're breathing faster.
Okay.
If they had an eye time of 1 and they're breathing, 40 times a minute, well, that's not going to give them any exhalation time, right?
Mm-hmm.
Enough air trapping. So we've got to have these really short eye times, especially the higher the rate, the shorter that eye time is going to be. Ashara, number 41, what MAPs would be considered adverse when applying PEEP in infants and children?
There is not greater than 15 centimeters of water pressure on page 1236.
right, and on here. All right, what level of PIP would be considered too high and could cause an increase in likelihood of ventilator-induced lung injury? Anybody?
Isn't that what she just said, to keep it lower than 15 centimeters of water pressure?
Okay, so she was talking about our MAP. I'm asking about your PIP.
Oh, okay.
If it went greater than 28, if it's greater than 28, then it would show increase.
Oh, yeah, okay, yeah.
in-
Thank you,
We
Taylor.
don't want to keep it less than 28.
That's on, there's like a little rule of thumb box. And right above that, in peak inspiratory pressure, it talks about that. So you really want it to stay in that 20 to 25 area, and you want to definitely keep it less than 28. All right, Amanda, what is HFOV and how is CO2 elimination determined?
All right, so this one I found the first part, and then the second part I had issues finding. I put it's a form of mechanical ventilation that uses smaller tidal volumes at rapid frequency. And then I couldn't find like how CO2 is like what the CO2 elimination is determined.
Is, okay, what, I just think, would it be the other part of that, where it says ventilation is provided by the to and fro movement of the large piston in the ventilator circuit that results, and then go back to the page. I don't know, I think I didn't.
And I read that, but I thought that said like that's how it is. That's how it's ventilated, but it doesn't say like the elimination determines like the level of CO2.
Yeah.
By reading it.
Really. She mentioned something about this in class, but I couldn't remember what she said, so I just remembered about the fast moving pistons.
I'm trying to find it in the book without just telling y'all exactly where it comes from. And I see where y'all are getting your statement that says gas exchange results from a combination of 6 mechanisms, bulk flow gas, so on. But I'm gonna post a handout on the oscillator that I think will help y'all understand it, or I'll have it printed out tomorrow. That talks about the different parameters on the oscillator, and I think it breaks it down a little bit easier for you. So we talked about some of the different settings, like the frequencies last week. The frequency, which is termed hertz, controlling the respiratory rate. And so 1 hertz, remember, equals how many oscillations or breaths per minute?
1 hertz equals 60.
Right.
So I found something like in other notes. It says something about like the amplitude equals the strength.
Yep, so your amplitude or your delta P or power, they can be called any of those 3 things, amplitude, delta P, or power. That's the amount of pressure variation or the oscillation or the wiggle, as I told y'all last week. And that is what's going to, if you increase it, it's going to increase your CO2 removal.
Okay, so I maybe just reading the questioning real quick. See, it's like looking for like like an end title CO2, like how is it determined? But I'm just like, what I read is like how it's, so I guess I'm reading it incorrectly.
Yeah, I want you to be thinking of like how is it removed? Like what settings would I change? What determines CO2 removal? And that would be the wiggle, so to speak. Okay.
Okay.
And that's going to be like the strength, how much wiggle they have. Okay.
Right, and that, because I remember you saying that, because I remember you saying that if it's the legs and stuff wiggling too, it's too much. You don't see, the wiggle in their torso, then it's not enough. But I remember you saying that, but I guess to me, I was reading like, how is CO2 elimination determined? So in my head, I was like interpreting it as like a number value, like for how we're gonna figure out what their CO2 is removed. So I was just interpreting the question.
Gotcha. I'm gonna show y'all. 1 second. Hold on, I'm trying to find a video for y'all so you can see what the oscillator looks like. Right, I'm gonna pull it up on this computer and share my screen with y'all in just a second. All right, can y'all see my screen now?
Yes, ma'am.
Yes.
I just muted it because you need to be able to hear the shaking sound. But as you can see, there's no movement in his head. Legs are not moving, but when they really went in on his chest, you could see that he had that good chest wiggle. That's what we're looking for. So they should be shaking from their collarbone down to their hip bones, roughly. So you can see that whole abdomen has that wiggle or shake to it. Okay? That help a little bit. The oscillator, that sound you heard in the background of that video, that was the oscillator. When oscillators are running, you can hear them the moment you walk into an ICU. And you can hear them throughout the entire ICU. And when one gets disconnected, you have never heard an alarm that loud in your life. They are loud. Which is a good thing, because you need to know. Amanda, was that your question or was that somebody else?
Fair.
Yours.
So sorry.
Alright, so 43, Andrika. What is inhaled nitric oxide and what effect does it have on the lung?
Okay, for 43, I have 20 ppm with the optimal response achieving when lung inflation is maximized. And that's on EGAN 1243.
And what's your normal dosage for nitric?
Don't know. Seeing if I can find it.
Is that, do you want her to answer it?
I'm sorry?
For anybody or just Andrew?
Yeah, anybody, if she can't find it, if you want to find it.
Is it the 20 ppm, is that parts per million?
Yeah. Recommended INO dose of 20 parts per million with an optimal response achieved when lung inflation is maximized. You can't really go over that 20 parts per million. And then remember I told y'all it is a slow decrease. And typically, Egan said typically done by 50% each step to a final dose of 1 part per million, at which point the drug can be discontinued.
So that was the next question.
Yeah, didn't we?
Oh, I'm sorry.
Answer that.
Yes, I just was going off of my own, something I wanted y'all to know and didn't look at the next one. I'm sorry.
I was over here looking for it and I'm like, wait a minute, I know I have that information. And then I look up and I'm like, oh, okay, it's the next one.
Sorry, AJ.
It's all good. I'll take the next one.
I took your question, so now you have to do 45. Yeah, I was just thinking to myself, that was something I wanted y'all to know. Identify conditions which affect the placental blood flow during pregnancy.
Alright, I got previous pregnancy complications, diabetes mellitus, pregnancy-induced hypertension, maternal age, placental previa, abruptio placentae, alcohol use, smoking use, and drug use.
Next one for flow. Identify the hazards, complication of endotracheal tube usage in infants and children.
Plato, it was like grooving, in the neonates, incisal enamel, hypoplasia in the neonates, accidental extubation, tube blockage, tracheal stenosis, esophageal perforation, and tracheal perforation. That was page 1230, box 53-1.
Okay. And last question goes to Taylor. When considering the use of high flow nasal cannula with infants and children, identify specifics regarding its use, the suggested flow rate, and its level of effectiveness when compared to nasal CPAP.
Evidence in preterm and term neonates indicates that using a high flow nasal cannula at a flow rate of 2 to 8 liters per minute may be as effective as and is easier to apply than a nasal CPAP. Instead of titrating levels of CPAP, the flow rate is incrementally adjusted. High flow nasal cannula systems may be beneficial in stabilizing acute respiratory failure caused by hypoxemia, which may reduce the need for non-invasive or invasive ventilation.
Good. All right. We've gone through the review for everybody. I will tell y'all your exam is 45 questions. You will do that next week, so you have some more time to study. You have the next 2 days in lab or clinical. If you're going to be at clinical and you think of a question, please let me know. I don't mind answering or helping out, telling you where to get some information. I do, like I said, I want to go through a couple of questions, just kind of quiz y'all on the review that we just did. I'm going to go through and just ask some stuff.